After an excellent talk, which is very common, now I'm calling for not very uncommon problem. Atrial fibrillation patient who is bleeding. How to approach by Dr. Dilip Kumar, MD DM Senior Interventional Cardiologist and Electrophysiologist, Manipal Hospital, Kolkata. Now he'll be coming online.
Good evening, everyone. Am I audible there and my slides are visible?
Yes, yes, you are audible and visible.
And then the presentation is also open.
अरे ये क्या है
Presentation is
ये तो
visible?
लेफ्ट
Yes,
रेक्टेंगल हो
presentation is
गया.
visible. You can go ahead.
Thank you, Alok and everyone for giving me the opportunity and the invitation. So essentially, this is a problem. I will be saving some time for everyone, and it will be a quick 7 8 minutes presentation on a very common problem. Atrial fibrillation who is bleeding, and even on NOACs and that too Eliquis, Apixaban, and that too a lower dose, and that becomes a very challenging situation how to deal with these patients. And we do have some options and which are really less explored in common practice, and that's what I'm going to show you with cases. So we have essentially these are my disclosures. I am a proctor for left atrial appendage devices, and I take honorarium and proctoring fees, and so as with for all these procedures, I am proctor. So when we treat AF patients, we look for heart failure. We treat rhythm management, and also we take into account the thromboembolic uh, aspect of the disease, and we treat these patients with NOACs and warfarin. So warfarin is gradually going down because of the INR problem, INR monitoring and all. So NOACs are the tool, main tool to treat these patients. But even with NOACs, you see, the anticoagulation used in patients with non-valvular atrial fibrillation is very pathetic, and that too with non-conventional doses also we see. So many patients, they are getting a 68 70 years frail lady, they are never being given full dose of apixaban, they are being given 2.5, so as with dabigatran, so as with rivaroxaban. So a proper dose of NOAC is being instituted in very less patients, and that too sometimes becomes insufficient to protect these patients from embolism. And we all know about the bleeding risk with these patients. We often see GI bleeding, bleeding in the CNS, bleeding, colorectal bleeding, and bleeding can happen anywhere. So let's go with two patients. So this was a 70-year-old gentleman, known case of hypertension, diabetes, hypothyroid. Patient had a episode of loss of consciousness. CT showed a mild atrophy with ischemic changes, and there was a small plaque in carotid artery. Patient had a atrial fibrillation, and echo showed mild mitral stenosis, but it was always more than 1.5 square centimeter, and ejection fraction was good. And so this patient was given NOAC because the definition of non-valvular atrial fibrillation is patient who is having moderate to severe mitral stenosis. Only these patients are valvular atrial fibrillation or with prosthetic valve. Rest MR, AR, mild MS patients are non-valvular atrial fibrillation, and we can treat these patients with NOACs. So this patient was given Hexaban, but after some time in 2022, the patient developed, again a CVA episode, and this was again a large area of infarct. So how we deal with this patient? This patient is now the patient was put on higher dose of NOACs, mild mitral stenosis. There comes additional strengthening these patients with left atrial append device, and you can see the transesophageal echocardiogram of this patient revealed mitral valve of 1.54 square centimeter, and you can see the spontaneous echo contrast of this patient. And then the puncture is done in T guidance, and once we go into the LA, then we have many options how to do LA appendage closure devices. I will be taking you all through each step by step in coming slides. So this was a patient who was having recurrent thromboembolism even on non-valvular NOACs, and then we were strengthening the you know treatment process to reduce the chance of thromboembolic episodes. The patient was discharged on DAPT, and the patient is still doing well. So the patient with atrial fibrillation with stroke prevention, if the patient is having recurrent events, then we can go for LF appendage, or sometimes like this patient. Uh, this patient whose angioplasty was done by me in 2009, CRT I did in 2019. The patient developed proximal atrial fibrillation, and then the patient was bleeding on 5 milligram twice daily apixaban. We reduced the dose of apixaban, the patient developed again a stroke. So the patient had a bleeding on normal dose of apixaban, reduced dose he is having CVA. Then we had no option to go for left atrial appendage devices. So here how we basically look for and approach a LA device. So we look for a T-guided septal puncture that has to be posterior inferior. So you can appreciate with the T images, you can now in two axis views, one is bicaval view and one short axis view, we look at the posterior inferior segments. This happens because the trajectory becomes, the pigtail and the catheter, the trajectory goes towards LA appendage if we puncture here, posterior inferior. So now you can appreciate how we are puncturing the posterior inferior. So, and once we go in LA, then we check with a small contrast or a pressure, LA pressure, then we advance the sheath. And in the T we can appreciate the sheath, you can see here, the sheath can be appreciated in the LA. And once we are in left atrium, we pass a wire in left upper pulmonary vein. And the wire, the normal thermo wire with JR catheter, we go in pulmonary vein. Then with JR, this thermo wire is exchanged with a superstick wire, and then the sheath is totally taken into the left upper pulmonary vein. With that, we take the pigtail. Now we maneuver the pigtail through this T guidance into the left atrial appendage. You can see here we are going with the pigtail into the LA appendage, and here is the, once we are confirmed, then we take our sheath into LA appendage. You can see how the sheath is taken in LA appendage over pigtail. If we don't take on pigtail, the chances of injury of LA appendage is very high, because LA appendage is a very thin structure. And then we take the device and then we release it, and the release should be happening inside the T guidance. Now you see the T guidance, and the LA is totally excluded from the LA. LA appendage is totally excluded. No, in T you don't see a flow, and then you release the device, and the device stays there. So these are basically the means we deal with patients who are bleeding on NOACs. We can reduce the dose of apixaban, or apixaban is one of the safest. You can try out apixaban again if the patient was on warfarin or dabigatran. But if the patient still bleeds, you don't have any option, you can go with appendage devices. The current guidelines position of this device is 2A in patients who are bleeding. But there is a recent report which has come, Closer AF trial, which has shown that LA appendage is not non-inferior to NOACs. So the default becomes a choice only when there is a bleeding. When there is no bleeding, you have the NOACs are superior. But if there is a bleeding, final choice is the left atrial appendage devices. And the safest NOAC in this situation is apixaban, if at all we have to give with that. Thank you so much for the patient hearing, and I hope there will be a little discussion on how you tackle patients and how do you feel about LA appendage devices and which NOAC you all feel the safest in bleeding patients. Thank you so much.
Now question is invited from the house.
Dr. Dilip, Dr. Avdesh is here.
Dr.
Hello.
Avdesh, good evening.
Uh,
Nice to
yeah.
hear from you.
Yeah. Very nice deliberation of left atrial appendage device closer. My question is that up to implantation of this device, up to how many months or weeks you advise anticoagulation, or we can stop anticoagulation just after implanting the device in these patients?
So newer devices like Lamprey or Watchman Flex, we can stop anticoagulation right after the implantation.
Okay.
We can straightway go to dual antiplatelet, and after 3 to 6 months, we can start on or give the patient a single antiplatelet only. So the patient will not require even dual antiplatelet after 3 to 6 months.
Okay.
So from that side, you are secure. But the only concern which has now arisen is the result of closer AF trial, which shows that in even bleeding patients, LA appendage closure is not non-inferior, and that trial has many flaws. They took into account cardiovascular death, they took into account bleeding as well as embolic events at a composite. So in a composite, you can't exactly see the efficacy how a device non-inferiority can't be judged there.
Okay.
So it's very safe device. I have done proctored around 50 cases all across India, and most of these patients are doing well without anticoagulation, only on antiplatelets, and wonderful follow-ups are there.
Thank you.
Thank you, Dr. Dilip. Dr. Alok
Thank you,
here.
thank you, Alok. Thank you so much. Thank you,
Thank you again for giving online lectures.
thank you. Thank you.
Okay, boss. So now I inviting Dr. Manoj to give memento to Dr. Jigyasu Singh. Once again, I request Dr. Manoj Srivastava sir to give memento to Dr. VB Singh sir. Now I request Dr. MK Maheswari sir. Sir, please give memento to Dr. Arun Singh. Now I request Dr. BK Singh sir to please give memento to Dr. Chandrasekhar Singh sir. Now I request Professor Vikas Agrawal sir to give memento to Dr. Balaji. I thank all chairpersons for conducting the session by a very nice